Good morning, CHG. It is Wednesday, the 8th of April, 2025. Now, many of you have heard through mainstream media of Daisy, who is apparently the second child to have died from measles. Well, did she? The medical records for Daisy have been handed over to Dr. Pierre Kory, Dr. Suzanne Humphreys, Dr. Ben Edwards, and our Chief Scientific Officer, Brian Hooker. And we have on the show today Dr. Pierre Kory and Dr. Brian Hooker to talk about the findings of what was in those records. So we're going to hand over straight away now to Dr. Pierre Kory and Dr. Brian Hooker. Welcome and good morning.
Good morning. Thank you.
All right, Dr. Pierre Kory, please can we start with you on what you found in Daisy's medical records?
Well, you flashed on the screen that statement, and I read very quickly from, I guess that was the hospital or the Texas Health Agency. That statement is 100% false, incorrect. That is not what the records show at all. I don't know if they reviewed the records before putting out that case. My sense is they probably just relied on the word of the doctors. But I did a very careful review, and I just want to say thank you guys for helping get at the truth. Before I go into this case, and I'm sorry if I'm going to editorialize here, but this is just getting exhausting. This constant fear-mongering by the media. I've already lost so much trust in the institutions of society, but to see them rampage like this on inaccuracies and peddling falsehoods and just distortions, it's terrible. It's terrible for our health. They're scaring people into getting what I think is a very dangerous vaccine by trying to scare them for what is typically an extremely benign illness. And you can see it in this case. So, first of all, this young girl was previously healthy until a month ago. And although I couldn't review the records before the two hospitalizations that were kind of back to back, from talking with the father, she started to become ill a month ago, not with measles. She was apparently diagnosed with mononucleosis. Subsequent to that, she then was diagnosed with strep and then a pneumonia and was treated and remained ill throughout. She was having persistent fevers. And then the records that I reviewed, she was admitted to, her first admission was to this UMC medical center. On arrival to the hospital, she was noted to have thrush, which concerned me because thrush means that you're in a state of immunosuppression. It can happen from high-dose steroids, which I believe she had gotten in some of her prior illnesses, but she was already, I think, in a very diminished shape. So she had this overgrowth of yeast, and at that time, she was in respiratory distress. She had low oxygen, and she was actually treated for secondary bacterial pneumonia. Their diagnosis was largely correct. They said viral illness with probable secondary bacterial pneumonia, and they put her on antibiotics. But let's be clear. This is the same hospital which the other child died. They again used the same regimen, which is ceftriaxone and vancomycin, which I very clearly, when we talked about the last child that died, is absolutely deviates from the standard of care. It does not cover mycoplasma, which is the most common one. However, in this case, she clearly didn't have mycoplasma. Not only the test was negative, but she actually responded to these antibiotics. So although it was inappropriate, they managed to hit whatever bug she had. I don't know what bug she had, but you can see from the record that she actually pretty rapidly improved. Fevers went down, oxygen requirements went down, she started to eat, she perked up, and within 2 or 3 days, she was discharged. During that admission, it was when I think her measles started because the mother didn't know that she'd had any rashes, and they found a rash on her. And you can see different descriptions of a rash. They tested her for measles, and on the day of discharge, measles PCR was positive. So she had measles, but she responded to antibiotics. So it was pneumonia on the first one. The problem is she was in an ICU, and when she was discharged, pretty much that day, she started to decline at home. She was getting sicker and sicker. And she was brought back to be readmitted, I think around 2 days later. And the second time when she admitted, now she's in really bad shape. with a severe pneumonia. She's requiring more oxygen. Her rash was described as fading. It was no longer a problem. They'd seen her before, so they described it. And she was again admitted to the ICU. And here's where a whole litany of very poor clinical decisions were made, which led to just gross mismanagement. And it's abundantly clear from the chart. So number one, they started her on antibiotics in the emergency room, presuming it was a pneumonia, and that was correct. She was having a worsening pneumonia. The problem was those antibiotics were stopped within 1 day. So she only got 1 day of antibiotics, yet she had a markedly worse chest x-ray than when she left. She now had involvement of both lungs rather than the left lung on the first admission. And clearly this disease was progressing. And it's clear from the impressions written by the doctors in charge that they were assuming that this was measles pneumonia. And that was a really tragic error. Because one thing that they overlooked in what's called their differential diagnosis is when someone is admitted who's recently been on antibiotics, recently been in a healthcare facility, particularly in ICU, who's immunosuppressed, you have to consider what's called a hospital-acquired pneumonia, or HAP. Hospital-acquired pneumonias are fundamentally different than community-acquired pneumonias. Those bugs that you get from being in hospitals have high degrees of resistance to typical antibiotics, and your standard approach is to really broaden using the most powerful antibiotics we have. Instead of doing that, they gave her their standard little local protocol, which is even incorrect for community-acquired pneumonia, and then they stopped at a day. And so for the next 3 days, you see this child decline. Repeated impressions by the doctors are this is complications of measles. And then around the 4th day or the 5th day, they decide she has another big fever, and they decide to put her back on antibiotics. And at that time, they send a sputum culture to see if there's a bacterial infection in her lungs. And I just have to be clear again, that is a deviation from standard of care. Anytime we admit someone to a hospital and we're starting them on antibiotics, especially broad ones, you send cultures so that you can identify what the organism is so that you can then narrow and target the exact organism. And also you're given sensitivities of the organism to antibiotics. So you can use the best and most appropriate and most targeted antibiotic. They didn't send sputum cultures on admission. Only until like day 4 or 5, and I could get my days wrong, but it's an egregious delay before sending a culture. They put her on their standard community-acquired protocol. Then the next day, first time is I think day 6 is the first time in the record that I see any doctor write possibility of a hospital-acquired infection. Day 6 is the first time this occurs to them. Then they broaden their antibiotics insufficiently and not according to the hospital-acquired pneumonia guidelines, which are really only been published for adults. I cannot find any specific pediatric guidelines on how to treat hospital-acquired infections, which I would say this case should be brought to the American Academy of Pediatrics. Our adult guidelines were published in 2005, and they still haven't done this for kids. That is absolutely unacceptable. And I've seen papers where they've had methodology on developing guidelines. That was in 2019. I still cannot find a pediatric guideline. So their choice of antibiotics was not well guided, and it turned out to be wrong. Because what happened is within 2 days, she declined, she could no longer be oxygenated, and she died. And on the day of death, the culture of her sputum came back. And it showed an organism called E. coli, which was resistant to almost all standard antibiotics. There was only 3 big gun antibiotics that would have saved her, and she was dead already by the time they got this information. And what's really the most damning and the most conclusive that she died of a bacterial pneumonia is that on that culture, they usually estimate how many organisms they see growing on the culture plate. And they grade that in terms of 1+, 2+, 3+, 4+. 1+ is likely contamination. You can't really say there's an infection. 2 is possible. 3, suggestive. 4 is strong evidence of significant infection. And what did she grow? 4+ E. coli, broadly resistant to numerous antibiotics. Too late. And I'm really, I want to also express some empathy for the physicians, because this is my belief. You might want to call me naive or being overly generous, but I think I could tell from the actions of the physicians, they were trying to help her the best way they could. I think they were doing the best they can. But what was evidenced in the care was either a combination of poor training, poor oversight, or minimal clinical experience or insufficient clinical experience, because all of those actions that I described, I mean, that is, again, medicine 101 to how I practice ICU medicine. I would never stop antibiotics until I'd ruled out an infection. If someone's declining, I would be doing more evaluations to find out what I was missing. One thing that they did is they tried at least a therapy that's not standard. At least they were trying to do something for her. They gave her intravenous immunoglobulin, but that's because they thought she had measles. That's not going to help in this severe bacterial infection. And the other thing that they did is when they stopped antibiotics, they continued her on high-dose steroids. For a girl with thrush who's been sick for a month with repeated infections, just got out of an ICU with a pneumonia, and now they leave her off of antimicrobials and just on steroids. Steroids are hugely beneficial in treating pneumonia if paired with an appropriate antibacterial. When someone's fighting a deadly infection, especially a highly resistant hospital-acquired one, and they're put on steroids, that assures the worst outcome possible, and that's what happened. And so these were oversights, poor clinical decision, poor clinical reasoning, and I just wish the level of medical training and experience was higher in this area of Texas, because this is the second case I've reviewed, and it's really somewhat shocking to me.
So to be absolutely clear with what you're saying, Dr. Kory, you're saying that Daisy did not die of measles. Daisy died of E. coli that was acquired in the hospital.
4+ E. coli in the sputum culture. And I didn't mention, you just brought up another thing, Polly, is another aspect of the medical record is something called what we call her white count, right? The number of white blood cells that are counted in the blood. When she came in, they were normal. Okay. What's interesting is that if you review measles pneumonia and how they present, typically, even in severe measles pneumonia, the white count is normal or low. Hers came in normal and started to rise and rise and rise. They went to 13 a few days into the admission. Then they went to 27. Still no antibiotics. Then the antibiotics were started. They came down a little bit, but by then she died the next day. And so this lack of emphasis on the importance of this rising white count, which is an alarm signal that there's something going on. This child is trying to fight an infection and failing. It's not measles. And it's also another thing that's commonly done in medicine is when sometimes in ICUs, when you have someone on steroids and the white count rises, that is an effect of steroids. But I've been doing this for a long time. I used to teach my students any white count over 20 cannot be attributed to steroids. And also, you should generally not, attributed to steroids is a diagnosis of exclusion, meaning once you've ruled out an infection, then you can blame it on steroids. You don't blame it on steroids up front. And again, this to me, as a highly experienced pulmonary and critical care physician, these were missteps, poor decision-making, and it led to another tragic death that, again, is being blamed on measles. I mean, in the second admission, numerous notes report how the measles rash was healing and fading and going away. She's recovering from measles.
Right. And now looking at the suspension of antibiotics, that to me really is astounding. It looked like they did a PCR test, and the PCR test was for respiratory ailments, respiratory viruses, and then I believe that MRSA and then Staphylococcus aureus were both on there. The PCR test came back negative for those particular organisms, and then they suspended antibiotics. That seems really, it seems very, very risky, because there were so many holes in that particular panel and so many other organisms that would have been treatable by antibiotics. It seemed like a really bad choice.
It was a very narrow testing. I mean, when you look at its face, a respiratory panel, right, it has this whole list of viruses, right?
Right.
Very little assessment for different bacteria. And I would do a respiratory panel with a bacterial sputum culture. I mean, that's what, I was talking to Dr. Ben Edwards earlier. I mean, that's medicine 101. I mean, anytime you admit someone with what you presume is an infection and you're going to start antibiotics, you send those cultures typically before the antibiotics because you want to make sure you can identify the accurate organism. And that was a fatal misstep.
Well, it seems like they would have at least narrowed down what antibiotic to use if they had done the sputum culture when on admission to the hospital. Then within 3 days, they would know the antibiotics that the organism was susceptible or sensitive to, and they could have saved that girl.
Yeah. I will be, it's interesting. Like, I got the medical records at 6 p.m. last night, and I was really intrigued, and I really wanted to see what happened with this case. And as I was reviewing it, it took me many, many hours because it's 2 hospitalizations, lots of pages. And
right.
Interesting, before I got to the conclusion, it was only at the end when I almost like gasped when I found that culture on the day of death, because while I was reviewing, Brian, I literally was thinking like, wow, it looks like this child was dying of measles pneumonia, because I didn't see the white count until later. And I saw that they were treating, and I was like, maybe this was a measles. Like, I was trying to be open and objective based on the evidence. And I couldn't find evidence that it was anything but measles until the end. And then when I really reviewed all of the steps, I made a spreadsheet and I looked at everything. That's where I was just picking out, wow, they didn't do this, they didn't do this, they did this, they did that. And then the case just, the whole picture of the case changed to a really tragic series of missteps.
Did they just presume that it was measles and then stop there and stop their critical thinking at that particular point in time? It seems like we're surrounded by measles furor and measles in the news, and it also seems really odd that her rash was fading at that particular point in time. You would think that if it was a measles pneumonia, that she would not be in that state where she was, presumably or seemingly recovering from the measles.
Yeah, I mean, I think that's fair. It's hard to pin down because I was looking at like when measles pneumonia happen, and they can happen at peak rash or like nadir, or like kind of in the healing of the rash. So it can happen during that time period. But to your point, there's repeated assessments over days that this was complications of measles in the lung and that this was a measles pneumonia. And like we just kind of talked about, I gave you all the data points to show that was incorrect thinking. And it was, we talk about that in medicine. We call it sometimes tunnel vision, like you tunnel in on a diagnosis or you anchor to a diagnosis.
Right.
And it's, it's something that you need to be taught and trained to always be open, always be exploring, always. It's called a differential diagnosis. Each day as I see a patient, if they're going the wrong direction, and, I think we talked about this in the last case, is that, the 2 guardrails that guided me through the ICU every day was, if what you're doing is working, keep doing what you're doing. If what you're doing is not working, change what you're doing. And again, I didn't see this as in that last press release of the hospital after the last death, where they literally put out a press release saying that we evolve with patients' conditions and follow evidence-based standards of care, which is an outright I'm going to call it a lie. It was easily disproven by the medical record. If they tried that press release again, that medical record would not support that. And there was not very deft and flexible adjustments of treatment.
Pierre and Brian, I just have a quick question to help me understand this, because I know viewers are going to be saying the same thing. So the child goes into hospital, parents completely unaware that she's got measles, no measles at home, nothing. And then we're supposed to rely on a PCR test that they say is measles and what they describe as a rash. Well, we can all have rashes. I'm just playing devil's advocate here because, quite frankly, are we sure she even had measles?
Well, the PCR is pretty specific. It's not always sensitive. It depends on the sample, but the PCR was positive. So I think that's pretty specific for measles. The descriptions of the rash kind of were inconsistent through the chart. There was, to your point, Polly, there was one description early on in the ER where the ER physician described it as kind of atypical for measles or not classic for measles. But then I saw other descriptions where it was more classic being described as measles. It started to involve the face and the torso. And so my sense is that she had measles. But again, like in the last case, who cares? Measles is not deadly. The complications of measles are, but in this era of antibiotics and sophisticated diagnostics and, experienced physicians, we should easily be able to take care of these complications. And again, it's hard to argue that this is a complication of measles when she had been sick for a month. She'd had repeated infections. That mono, I think, led her down this very deteriorating health status. And so she was getting like weaker and weaker. That's when she picked up strep. Then she picked up measles. Then she got a pneumonia, treated for the pneumonia, and then picked up a bug while in the ICU. And so it's, it required deft, observant, and aggressive doctoring. But I really think the main point here is the not sending of a bacterial sputum culture on admission led to a misdiagnosis and insufficient and inaccurate treatment. And this, had that culture been sent, they would have had the bug, they would have had the sensitivities, and boom, they could have started the right antibiotic, and I believe she would have turned around.
And lots of drugs as well, I understand, from Dr. Suzanne. She was on lorazepam.
Lots of Tylenol and ibuprofen. I thought Kathleen Humphrey's review of how damaging and how harmful fever reducers are in terms of when patients are septic and fighting off infections. I mean, you're literally handcuffing patients' abilities to fight off these infections. I can count. I have to look at my spreadsheet, but at least 10 doses combined of ibuprofen and Tylenol around the clock throughout. I mean, it's just, again, and here's the thing, Polly and Brian, I mean, we have this, we did an interview, a week ago, 10 days ago, around this other child's death. And again, I'm trying to be supportive. I try to be an educator. I want to put out good information and guidance. And I was very clear with some of the teaching points, like don't treat communicable pneumonia with that combination. Don't use, and Kathleen was saying, don't use the fever reducers, right? Consider things like IV vitamin C. I'll leave that alone. But just kind of basic stuff that will give a child a chance to have the best possible outcome. And apparently they don't watch this, even though it was all out there in social media. Why isn't the hospital? I mean, if I was the infectious disease director at the hospital or the chair of medicine at the hospital, I would have said, what happened in this case? I would have seen what happened. And I would call a meeting with all the attendings. I'd be like, guys, let's review the treatment of community-acquired pneumonia. Here we are a week or two later, and they're using the same protocol on that first admission, the same combination of vancomycin and ceftriaxone. They're not using a macrolide like azithromycin. And so are they not learning? Like, why are we not have the capacity and openness to learn and change direction and do better? Do better.
Do you think
Carry on, sorry.
I'm sorry. There's just such a fixation in the charts about measles pneumonia and pneumonia caused by measles, and then also the terminology unimmunized, unvaccinated appears over and over and over in the record. And it seems like if they weren't so fixated on measles, maybe they wouldn't have forgotten or ignored doing a sputum culture on admission. I mean, it seemed like that was their crutch. That was the crutch that they got to lean on, but yet they missed everything else because it kept on being diagnosed as measles pneumonia.
Brian, that's so true. Again, that's what as soon as they tunneled in on that, they forgot about the other stuff. But
right.
Let me make a comment on and this is a message to all physicians out there. This is now getting me enraged. I am enraged by this. To see in a medical record, in a history, every introduction describing that child that she's unvaccinated, tell me what the difference is treating a vaccinated or unvaccinated child who has an illness. Why does it matter? I saw this all during COVID. Every supposedly unvaccinated patient in the hospitals, and most of them were vaccinated, just wasn't recorded correctly. Every time someone dying with COVID, they have to start off 73-year-old man unvaccinated for COVID. I mean, it's almost like this righteous judgment that they're constantly like, this is what you deserve for being, and the reason why they're having that psychology, and I'm sorry if I'm going too far, but it's the media. It's the media that's demonizing the unvaccinated again. You got what's coming to you because you didn't listen to us and get this dangerous vaccine. No, I didn't get vaccinated because measles is benign. A few kids might get complications, but I trust in my doctors and my healthcare system to take care of me and just treat the infection. And we can't even do that. Instead, we have to put judgments in medical records, which is absolutely unprofessional and egregious.
I couldn't agree more. And we saw the same thing over and over again. Polly saw it ad infinitum on the bus, where there was a level of judgment, there was a level of difference in treatment. I'm not suggesting it in this particular case, but it just seemed like it was so easy to lean on the measles and to look at so many different evidences that were going on that said something completely different.
Yeah, I agree, Brian. It has to stop. It has to stop. And again, I want the more senior doctors in that hospital to review these cases, take the appropriate steps. We live and learn. When we make mistakes, we always do what's called root cause analysis exercises, where we look at the missteps that might have led to a poor outcome. That is standard behavior of a functioning hospital. And I don't know that they've completed the last one, because had they done that, I don't think we'd be here again.
And they did vent her as well, did they not?
I'm sorry?
Ventilated. Daisy was ventilated as well, so I know our viewers.
Yes, but I will tell you that part is, I don't find any fault with all of their attempts at oxygenating her. I think they put her on at the appropriate time. I think all their other escalations of oxygen. But remember, oxygen is supportive care. It's not a treatment for the cause of the failure of oxygenation. It's just supporting the oxygenation. So they did a great job with doing that, but you have to treat the underlying cause that's rotting the lung.
Exactly. If the lungs are smothered in pus, then oxygen cannot get through.
I used to use maybe it's a crude term to people, but these kind of nasty bacteria, I used to call that they turn the lungs into bags of pus. They're drowning in pus. And so you're losing all the air sacs. And as all the billions of air sacs we have start to fill with fluid, you're losing the amount of area for gas exchange. So then you have to go into these heroics and start cranking up the oxygen and putting them on ventilators and using high pressures. And, if you're on appropriate treatment and you do that for a while, you can turn people around. I've been doing it my whole career, but you got to get the treatment right.
And this really screamed out that something was going on very, very wrong with the bacterial infection. Not only was it a 4+, but a 4+ 24 hours after culturing. So that's an infection that came up very, very quickly. And even on inspection, before they actually did the culturing, they did a microscopic slide. And even on inspection, they saw what were called gram-negative rods. That is, a description of E. coli, and it's an odd-looking rod. It's a stubby little rod, and so there was evidences that they were going in the wrong direction, and so much of this could have been avoided, like you said, if they would have done a sputum culture on day one, on admission.
I agree.
So we've lost two little girls in the same area, same hospital. Right. A 6-year-old and an 8-year-old, beautiful girls in the Mennonite community. Do you believe, both of you, that with the right protocol, under the right care, those girls would be alive today?
100%. I think absolutely. I can't say 100% because I can't say that because of her premorbid status. She really, the poor thing really started to deteriorate from months. So she was very, very weakened. She'd just been in an ICU with a pneumonia. So obviously, I can't say she absolutely would have, but I can say that she was not given the opportunity, the correct opportunity. She would have had a very, very high chance of turnaround. These antibiotics work. I've treated really bad pneumonias before. You get a good antibiotic at the right concentration, at the right frequency, you start killing these bugs and the patients start to heal. Inflammation goes down. The amount of pus that accumulates decreases. So she would start heading in the right trajectory. I know when I've instituted correct therapies, the trajectory changes. All I saw was a downward one, and that's reflective of incorrect or inadequate or really lack of therapy. She was on no effective therapy through that hospitalization that would have treated the true cause of her demise.
And very little brainstorming and very little course correction that reflected what was going on in the laboratory analyses and the laboratory work. It seemed like there was a lack of interest. I hate to say that, and maybe that's ascribing motivation to it, but maybe a lack of curiosity in terms of what was going on. And I think it's rather unfortunate. And when you look at the very, very minute role that measles played in this entire scenario, being diagnosed with mononucleosis, with a positive diagnosis of Epstein-Barr virus, which causes mononucleosis, and then having measles as a secondary infection to mono when she had been already diagnosed with chronic mono, and then having a bacterial pneumonia which she recovered from, and then another bacterial pneumonia that was missed because it was called a measles pneumonia. I mean, it seems like in the grand scheme of things, measles was really a small part of this case.
I agree 100%.
So we are saying that both of these children did not die of measles, because the press are making a big thing. People are running out to get their MMRs because they're petrified.
That's right.
Both these girls did not die of measles, categorically, 100%.
They died of bacterial pneumonias, which are common after any viral infection. It can happen after measles, after flu. I have a daughter who had one after the flu. I mean, these are things that to be expected. I mean, I was reading yesterday, Dr. Bartlett, Dr. Ben Edwards, they're down there and they have a high index of suspicion for pneumonias. They're treating measles. They're giving, vitamin A, budesonide, and clarithromycin. So they're treating a good community-acquired pneumonia antibiotic, and they're avoiding these things. And after they review these cases, I hope they continue and step up their efforts, because depending on a hospital, to really be able to evaluate and treat correctly is the expectation that's set too high, and which is a strange thing, Polly, because I got to tell you, pneumonia is one of the most common diagnoses in all of medicine. It is not a zebra. It is not a rare thing. We have pretty established approaches over decades on how to treat appropriately, how to work them up appropriately. And I'm not seeing that in that area of Texas at that hospital. And I really think they got to bring someone in there, bring in the Department of Health, get a pulmonary expert. Come down there, do some lectures, do some remedial training. I mean, get this to stop.
Couldn't agree more. Dr. Brian Hooker, Dr. Pierre Kory, thank you for all your hours going through these medical records, which were signed over from the family, especially to these 4 doctors. Thank you both for your work and for being on the show this morning.
Thanks, Polly. Thanks, Brian.
Thank you very much.
Okay, everybody, I'm going to hand you over to Dawn Richardson now for Advocacy Lifeline.